Hello everybody, welcome back to DaVinci Academy's Chapter 7 unit of Head and Neck. Here we're going to discuss the eye and the orbit here in Lecture 10. So the eyes are one of the most complicated organs in the whole body, yet it's also one of the most vulnerable organs because it's such close proximity to the brain and the outside world. And what do the eyes do? So everyone knows the eyes pretty much help with vision. That's exactly what they do. They take visual stimulus, they take light stimulus, they transmit it through the eye, through the optic nerve, and they put it right into the brain and help transform this information into visual information that we can use on a daily basis. So what is the orbit? So the orbit is just this bony encasement that surrounds the eye, that protects the eyeball, that provides structure to it so that it allows it to do its function. So the orbit has pretty much 4 walls and 2 fissures. There's a medial, lateral, superior, and inferior wall, as well as a superior orbital fissure, an inferior orbital fissure, and of course the little optic canal where the optic nerve passes through. So before we go any forward with the eye and the optic nerve and the orbital canal and the orbit, we're going to first go over the eye signal relay system. This is a very, very important topic, and regardless if you're doing anatomy, neuroanatomy, you're doing any other sort of clinical examination, this is something that's going to be tested and tested upon many, many times. So as we mentioned, the eyes are this interface for relaying this visual information and making it into useful photographic information you can use on a daily basis for useful, purposeful information. So how does this work? So what happens is light actually will enter into the cornea as first structure. It'll pass through the pupil, which is the dark portion of the eye. Then it passes the lens, which helps with refinement and focusing. It goes through the vitreous humor, which is just the fluid. It hits the retina. Then the retina will then take all the information, transmit it through the optic nerve. It will pass through the optic nerve and go to the optic chiasm, which is right here. And the optic chiasm will become the optic tract, which is right here. And the optic tract will then synapse on the lateral geniculate nucleus, the LGN of the thalamus. Then the LGN will go off optic radiations. It will either go up or go down. So either go temporal or parietal radiations. And then eventually they'll come back and provide innervation to the occipital lobes in the back of the head. And that right there is how all of the electrical stimulus from the visual stimulus is actually relayed. So if you memorize that, you'll be able to get that correct, and you'll know how light and visual stimulus works. So we're going to go a little bit more into the eye relay system and just kind of break things down so you know how to pick them up in a clinical situation. So just some brief summary points. Your left and right eyes relay information from both the left and right visual fields. So that might be a little confusing, but if this is you looking out into the world, right? So this is out into the world, like we're looking into this computer screen. If you were to split it up into half, this is your left eye and this is your right eye. Your left eye sees the left visual field and the right visual field. Your right eye also sees a left visual field and a right visual field. So your left eye does not just control your left eyeball, it doesn't control just that left side, it controls visual fields. It doesn't control just eye vision, it controls visual fields. That's the difference here. That's the big thing about how people get confused with eye relay system and how the eyes work. Your eyeball controls 2 visual fields. It doesn't control just one visual field. It controls 2 different visual fields. And if you look, your temporal retina, which is the retina that's located kind of by your ears, this controls all the medial visual fields. So if you follow these red lines right here, this is your temporal retina on the outside, and this is your nasal retina on the inside. So what happens is your temporal retina actually gets stimulus from this direction. And your nasal retina gets information from this direction. It crosses over. And that's what's so difficult for people to understand. So if you can see here, light comes in this direction, hits the nasal retina, and provides information about the left visual field. This one can provide information on the right visual field. Temporal provides information on the left and the right, but all of this is considered to be central vision. Does that make sense now? This is all central vision. So your temporal retina controls your central vision, and your nasal retina controls your peripheral or lateral vision. Okay? Just make sure you understand that. Temporal, central, nasal, peripheral. Then you have your optic chiasm, and this is actually where you can see these nasal retina fibers will actually decussate. They'll cross over at the optic chiasm right here. But the temporal retinas will remain ipsilateral. They do not cross over. They continue this way and continue this way. So these are some really 2 important high-yield clinical situations that are often involving the optic chiasm. If you have compression right here, usually by a pituitary tumor, you're going to get tunnel vision because you're going to lose the ability to see over on this side and lose on this side, so you can only see here. So you get tunnel vision. You could also get injury to the lateral chiasm, so right here, and you're like, how the heck is that going to happen? Usually it's like calcified internal carotid artery because it runs right close to this chiasm. If that happens, then you're gonna have a central vision defect. You can only see out here and here. Okay? So now we're going to go over the eye relay system in a little bit more detail and show you kind of how it's going to present. So if you have an optic nerve lesion where that black line is, you're going to get complete ipsilateral vision loss on that right side. If you have an optic chiasm medial lesion we just discussed, it's the more common one, you're going to get tunnel vision. Well, the white is normal, the black is lack of loss of vision. So if you see white there, that's what you see. Black is what you don't see anymore. So optic chiasm in the medial aspect, tunnel vision. If you get an LGN lesion, you're going to get complete loss of the ipsilateral visual field. So for example, if you have a right lateral geniculate nucleus defect, you're going to get a right visual field defect. Okay? Because remember, it's all about the visual fields. It's not about the eyes, but the visual fields. If you get a temporal optic radiation lesion, so this is where remember the radiations can either go temporally or they can go up in the parietal area. If it goes temporally, you're going to get loss of superior quadrant visual field. So you get that. It's quote unquote called the pie in the sky defect. So if you see a pie in the sky defect, temporal. If you get I guess pie in the floor, but it's really not. It's a parietal optic radiation lesion. So temporal, pie in the sky. Parietal, down below. Then my favorite one of all is the occipital lobe lesion. This is where you get loss of like circumferential pattern of visual loss and a hemi-visual field, but it's going to be macular sparing. You're going to get like this half circle in the middle, and then it's classic. You're going to know that's an occipital lobe lesion. The reason why is because even though the occipital lobe is where you get all your visual stimulus, housing all your visual stimulus, what actually happens is that the macula, which is such a dense network of nervous fibers from the retina, actually has fibers going everywhere. It just goes so many different portions of the occipital lobe that is not really yet known, and because of all those different fibers going to different parts of the cerebral cortex, you actually do get macular sparing. So now we'll discuss the orbit. So the orbit, as we mentioned, is this bony encasement for the eyeball. It's a pyramidal-shaped structure that houses the eye and protects the neurovascular structures. And it has those four walls, those two fissures, and that optic canal, or that optic foramen. So, talk about the medial wall. The medial wall, so if you imagine this is your nose, as you can see the nasal opening right here, it's the nasal cavity. This is your medial wall right here. The medial wall is composed of the maxilla, the ethmoid, the lacrimal, right here, and the sphenoid bones. It's thin, it's weak, and it oftentimes can get fractured and disrupted in some sort of pressure, like base injuries. Then you get the lateral wall. So lateral wall is stronger. It's made up of sphenoid and zygomatic, which is a very, very strong bone. It also houses a lacrimal gland right about here. Then you got the roof. The roof is again from the sphenoid and the frontal bones. It's also very strong. You got the maxillary sinus right above it. Then you got the floor, which is the maxilla, the zygomatic and palatine bones. This is also weak. So the two weakest parts are weak, weak, strong, and strong. So when you have some sort of pressure-based injuries, you can actually have the contents of the eye going into this direction or going down in this direction. So we're going to talk about these fissures. So the first one is your superior orbital fissure, and this is located between the greater and lesser wings of the sphenoid bone. It's the one over to the right, circled in red, and it has, like I mentioned before in a previous lecture, it has all the big guns. It's got your cranial nerve 3, cranial nerve 4. It has your NFL, your nasociliary, your frontal, and your lacrimal branches of CNNV1. Love the NFL because you'll never get that. You'll never get the branches of CNV1 wrong ever again. Then you also got your abducens also passing through it, cranial nerve 6. You have the superior division of the ophthalmic vein, and you also have sympathetic nerve fibers, of course, just running along with any sort of arterial network. You can also see in this image here, this is actually a really great image showing you the superior orbital fissure as well, and as the contents are coming through it. Then you got your inferior orbital fissure. This is between the sphenoid bone and the maxilla. It's actually really tiny. If you can see down below, that's where it is. It actually holds the contents of the inferior division of the ophthalmic vein, the zygomatic branch of CNV2, the ascending branches of the PT ganglion as they go and innervate the lacrimal gland, and of course you also have your inferior orbital vessels as well. So now we're going to talk about the different components of the eye. So this is going to get a little bit long, but bear with me because all this is pretty important when we talk about the anatomy of the eye. So overall, the eye is very flexible, soft tissue filled with fluid. and it has numerous different components that are all important for helping with visual stimulus and conversion to electrical signals. So the first structure that light passes through is this cornea. It's a very transparent outer covering of the eye. It protects the anterior chamber from the outside, and it's actually what is considered to be the majority component of the eye's total optical power. And the reason why it's transparent is because if you had blood vessels coursing through it, you wouldn't be able to see. All the blood vessels would be passing through. So it actually relies on diffusion to get all of its nutrients. And it's innervated by CNV1, the ophthalmic nerve, and it's important for the corneal reflex. So when you touch this, the CNV1 will feel it, and then CNV2, which is the facial nerve, will actually help you with your orbicularis oculi actually blink. It has multiple layers. So the ones you know are the anterior corneal epithelium, the Bowman's layer, the corneostroma, and the descemet's membrane, the endothelium. And those are the 4 layers. And remember, the cornea is actively dividing, and it's an active structure. So even if you have a corneal injury or a corneal abrasion, you can still actually, you can recover from it time and time again. If someone with contact lens scratches their cornea, it just takes some time, but the cornea will actually regenerate and actually heal itself. So again, this whole concept I mentioned, anterior chamber versus posterior chamber. So anterior chamber is pretty much any structures from the lens forward, and then posterior chamber is pretty much anything from like the iris lens posterior to the retina. And the reason why it's important is knowing what the anterior chamber is and its relevance to glaucoma, as we'll discuss later. So what is the iris? So the iris is the circular structure located in the anterior chamber that controls the pupillary size and adjusts the amount of light that allows the retina to enter, especially based on the day and what your purposes of visual function is for that moment in time. And the iris is also important because this is what determines eye color, what everyone's favorite, everyone's favorite portion about the eye. So then you got the pupil. So the pupil is that very dark portion of the eye. It's the one that's almost like the center of the eye. This is where light actually passes through. It's controlled via the relaxation point of the iris, relaxation and contraction, and actually will change its size. So pupillary constriction, that usually happens with a parasympathetic innervation, and pupillary dilation happens in sympathetic. Again, think about the whole fight or flight thing, which is sympathetic, right? If you're trying to flee, you got to find out what's the best avenue, what's the best way in which I can escape my current situation. And that's going to be, you need more light entering into your eye, so you need to be dilated. So that's how you know sympathetic is dilation. And then parasympathetic is constriction, because you don't need light, you just need to relax, you need to calm down, you don't need much light coming in, right? That's how I remember it. And often, clinically, it's described as mydriasis and meiosis. And again, that's confusing. It's like these 2 words are very similar. How do I know the difference between dilation and constriction? Again, the D. The D in mydriasis and the D in dilation. That's how I remember it. So the next is the lens, and this is a transparent structure posterior to the iris that helps refract light. It also helps with the ability of accommodation, which means it changes its shape and controls the distance that light is allowed to pass through to help focusing for objects near and far. And this is very important. Like if you take your finger and stick it out at arm's length and move your hand forward and backwards, try to keep your eyes focused on your nail or the tip of your finger, you can do it. It's not difficult. You actually see your finger come in and out, and the resolution is still great. And that's because your lens are accommodating as you're doing that. So over time, when age-related cataracts can occur, or even congenital disorders like galactosemia, rubella, or toxoplasmosis can actually cause cataracts. And then when that occurs, the lenses are damaged. You got to go in, you got to remove them, and put a synthetic lens in place. Then you have a structure called the ciliary body. So the ciliary body is important because this is what adjusts the zonule of Zinn. So the ciliary body epithelium also produces the aqueous humor and fills the anterior chamber. So it has 2 important functions. It adjusts the zonule of Zinn and helps in contraction and relaxation of the lens. And it also helps produce that aqueous humor that fills the anterior chamber. So the ciliary body is located right about here. This is the ciliary body. This is the zonules of Zinn. This is the anterior chamber. This is the posterior chamber. This is the lens. And then this is the iris. And this is the pupil. And pretty much, again, talk about in terms of glaucoma. The ciliary body is very important in glaucoma because it can actually have obstruction at this area called the canal of Schlemm, and if you have obstruction there, then you get glaucoma, because that is where this anterior chamber fluid, this aqueous humor, is actually recycled. And all the short ciliary nerves actually innervate the ciliary body and allow for the contraction and relaxation of the zonules of Zinn. So then we're going to talk about the vitreous body. So the vitreous body is in the posterior chamber. This is the vitreous body in the posterior chamber. It's a gelatinous fluid that's located between the retina and the lens, and it's actually very, very kind of like a thick jello-like consistency when you're younger. And then when you get older, it becomes a little more liquidy. And what happens is then it's a little more fluid. It provides the eyeball with a flexible shape, and it's actually that very unique shape, that spherical shape. and it allows light to pass through it. If there's any sort of debris or thickening, it can cause floaters to occur, and this is just when you have like debris in your vitreous body, and then your retina picks it up as some sort of like artifact or some sort of interference. And like I mentioned before, when you're younger, your vitreous body is very thick, and these floaters can be present for months or even years. This debris can be present for a long period of time. When you're older, when you get older and this vitreous body kind of thins out a little bit, you can actually have your floaters will actually, pretty much by gravity, will actually float towards the bottom of your eye, and you will no longer pick them up sometimes. So again, this vitreous humor, it can become thick, or it can become very different consistency than it usually should be. And when that happens, it can actually even pull traction on the retina and cause some sort of detachment or even retinal tears. And then sometimes you even have to go in and do a vitrectomy, where you remove the vitreous body, you put in a substitute, and you allow the retina to kind of heal itself, or you have to do some photocoagulation to help seal the retina. The conjunctiva, everyone knows what the conjunctiva is. It's the white of the eyes, right? It's a little thin film that covers the upper and lower eyelids, as well as the sclera, and this is what can get conjunctivitis or some sort of hyperinjection or erythema whenever there's some sort of inflammation or irritation to the conjunctiva. It's innervated by the supraorbital nerve, the supratrochlear, infraorbital, lacrimal, long ciliary nerves. Then you have your sclera and the choroid. Your sclera, this is the white of your eyes. So the white of your eyes, people think is a conjunctiva. The conjunctiva is actually a thin layer that covers the white of your eyes, and it's highly vascularized and it's covered by the conjunctiva. The choroid is another vascular layer of the eye that provides primary blood flow to all of the retina, all via diffusion, because the retina cannot have vascular structures passing through it because of all the dense necessary rods and cones that have to be present. So speaking on behalf of the retina is a very unique structure. There's nothing else like in the body. It's about 1/10 of an inch long, and it's very important because without it you cannot see. And it's highly dependent on vascularization because your eyes are constantly working and they're constantly requiring energy, so they're constantly being perfused via that diffusion from the choroid plexus. So it is the most posterior structure in the eye. It's where light is received and electrical signals are transferred into the optic nerve. It has 10 associated layers, but most notably is the rods and the cones. So the rods and cones are very important because they fulfill different functions. They're both photoreceptor cells. The rods are located in the periphery and are responsible for night. The cones are located in the central. There's fewer of them, and they're responsible for color vision and fine resolution. So if you were to schematically, just rough estimate, tell you where the cones are, these are where cones are, and then these are where rods are. Okay? Then we talk about the macula. So the macula is a portion of the retina. It's visible in a fundoscopic examination. It has 3 different regions. It has the outer region, the middle region, the inner region, just called the perifovea, the periofovea, or the fovea. It's a circular shaped region that houses the fovea. Go figure. And it's important for high resolution and colorful vision. It's a high density of cones that are present in the macula. And it's located right here. Then you have the fovea itself, which is a dense collection, again, that cone cells in the middle of the macula. So if you imagine that this is the macula, and this is the fovea, right in the middle. Then you also have an optic disc with an optic cup. The optic disc, this is located medial to the macula. So right here, this is your optic disc. It's medial, so if this is medial this direction, then this is where your nose would be. And it has no rods, it has no cones, and it's actually the blind spot. There's actually no photoreceptor cells right here. So there's actually nothing relaying signals. This is just where you have the passageway of vessels, the optic nerves, the blood, and the veins. That's what passes through here. So this is literally a blind spot. But your contralateral eye actually understands that and compensates for that defect. So now we're going to talk about extraocular muscles. So we talked about extraocular muscles before. We're going to talk about them later. I mean, this is a very important topic of conversation because they're so important with how the eyes work in a clinical situation. So these are extrinsic muscles in relation to the eye. They attach to the orbit and orbital structures in the posterior portion of the orbit. And they do rotational and axial movements, up, down, left, right, rotate, angulate. So there are quote-unquote considered 7 extraocular muscles, and we'll go over all of them. So you have 2 big guys right here. You have levator, palpebrae superioris, and superior tarsal muscles. These aren't just important because they help with elevation of the eyelid itself. They don't do anything else with movement of the eye. These are just important for what we call eyelid raising and eyelid lowering. Then you have your extraocular muscles here in the chart here. You can go through this. You can take your time walking yourself through this. It's very straightforward. It's not too bad. The biggest things to know are its functions and to know its nerves. This is probably the most important origin insertions you're going to have to know. But you have to know what the innervations are, and you have to know what their functions are. And it's not bad. people, again, use certain mnemonics. You know what? For me, I just figured it's better off to just learn it and just move with it. So your superior rectus is cranial nerve 3, inferior rectus is 3, your medial rectus is 3, lateral rectus is 6, superior oblique is 4, and then your inferior oblique is cranial nerve 3. And then they pretty much do the functions in which they exist at. So superior rectus goes up, inferior rectus goes down, medial rectus goes medial, lateral rectus goes lateral, and then your superior oblique, which is your one that goes down and in, right? Remember going down the stairs, superior oblique going downstairs, and then your inferior oblique, this one goes up and out. Now we're going to talk about the eye and the orbital nerves. So there's a lot of different dense networks of innervations and vascular supply to nerves. So we're just going to walk you through it and just briefly describe what the important ones are. So you have your short ciliary nerves, which are parasympathetic nerves, and they come from the Edinger-Westphal nucleus and help with the ciliary ganglion with that pupillary constriction. Then you have the lacrimal branches from the PT ganglion, and these help supply the lacrimal gland for production of tears, more or less. And your sympathetic nerves, and like all sympathetic nerves, they run along a vascular system. They rise from T1 at the highest point of the intermediate horn of the spinal cord. They ascend through the stellate and superior cervical ganglion. They run up along the internal carotid artery. They then go through the ophthalmic artery to provide innervation to the eye structures that way. Then you have your cranial nerve 2, 3, 4, and 6. Cranial nerve 2, of course, is your optic nerve. It's what receives the visual stimulus from the retina. It goes through the optic canal, and it pretty much is what goes to the optic tract, chiasm, and so forth. Your ocular motor, your trochlear, and your abducens are provide extraocular muscles innervation, and they also run through the superior orbital fissure, and they're just located as well in close proximity to the cranial nerve 2 as well. Then you got your cranial nerve V1. This is your ophthalmic division, and this is the one that provides sensation, purely sensation, no motor, to the orbit, conjunctiva, cornea, the ciliary body, the iris, the eyelids, the forehead, even the portion of the upper nose and medial cheek. It has very important branches, the NFL. This is the famous NFL, right? So your nasociliary, which is a sensory root of the ciliary ganglion, helps control pupillary constriction. You have your anterior ethmoidal nerves, you have your long ciliary and infratrochlear, and it provides sensation to the nasal cavity, periocular region, and the nasal region. So knowing you got your nasociliary, you got your frontal, and then you got your lacrimal. So frontal, again, this is your supratrochlear and supraorbital. This is sensation to the forehead. You got your lacrimal, smallest branch of CNV1. This provides sensation to the lacrimal gland, some of the conjunctiva, as well as the upper eyelid. And make sure you know NFL, or the branches of CNV1. It's almost always going to be tested and often even questioned on in a clinical situation. So now we'll break down the arterial and venous supply to the eye. So the main blood supply to the eye is the ophthalmic artery, and this is the first branch off the ICA. Then from there, the ophthalmic artery has numerous different branches. Supraorbital, supratrochlear has a little division to that. It has the anterior and posterior ethmoidal arteries, the dorsal nasal artery to provide external nose vascularization, central retinal artery to provide majority of the blood via the choroidal system to the retina, short and long posterior ciliary. I mean, there's just so many. Lacrimal artery, superior inferior muscular arteries. It's just a lot. And is it going to be tested on in cadaveric dissection? Probably not, because it's really hard to tell. The big ones that you're almost always going to be tested upon are central retinal artery, and then these two are often easy to find. And then, of course, these are easy to find based on how they kind of go towards the cribriform plate. And if you're looking like a superior inferior dissection with the top portion of the orbit removed, you can actually notice the anterior ethmoidal diving forward anterior and the posterior diving through posterior, and you can pick that up pretty easily. Venous system. So the venous system is pretty much named for the parallel system, and it works either in two manners, retrogradely through the cavernous sinus and then into the interjugular venous system, or can even have branches that go toward the pterygoid plexus and the midface, and then go through the external jugular system, transverse facial, inferior facial, or superior temporal veins, and drain through the superior system of drainage. However, it's the majority of the venous drainage for the eye actually goes posteriorly into the cavernous sinus, into the durovenous sinus system. So now we'll discuss some important clinical pearls. So we talked about glaucoma, we talked about the anterior and posterior chamber, and we'll kind of just break it down. So glaucoma, what is it? It's a commonly tested and very commonly clinically seen condition in people, most likely elderly individuals, and it's a pathologic situation in which the vision and health of the eye is actually compromised. And what happens is glaucoma just means that the pressure is too high in the eye. The intraocular pressure is too high. And it can either be because there's an open angle glaucoma or a closed angle glaucoma. When you have an open angle glaucoma, this angle is normal. It's fine. It's a normal iris to cornea angle with just clogged fluid. So that canal or phlegm going in this direction is clogged. So since that's clogged, this fluid here starts to accumulate and build up, and the pressure builds up. Then you have a closed angle, in which this angle is actually closed off. So it's actually a very acute angle like this. And what happens is, the fact that the angle is so tight and so closed, you cannot drain fluid as accurately and as easily. And what happens is the pressure gets so big, so great in the eye that you start to actually compromise the nerves. The nerves start to die, the vascularization starts to decrease, and then it just starts to have hypoperfusion of the eye, and then your vision loss. And then you eventually can go blind. But the difference in how they present, very significant difference in how they present. Open angle, when it's just like a clogged drain kind of problem, is gradual onset. It has vision loss that's gradual as well, and no pain. Closed angle is the one that's more acute. It's sudden onset. Your heart feels hard as a rock. You try to touch it, and it's very painful, and you do pretty much get very immediate vision loss. And these often have to be managed either surgically when it's acute, or with some sort of drop-based medication when it's an open angle. And there's another topic, it's called amaurosis fugax, and this is a very characteristic presentation when you have transient loss of vision loss. And it's most commonly due to like an atherosclerotic emboli that then showers off into the ophthalmic artery, occludes the central retinal artery, and then you can't see. It originates, again, usually from the carotid artery, common carotid, and then kind of something's getting showered up towards the ophthalmic artery. And you can use a duplex ultrasound to kind of figure out if someone's at high risk for this, because things can be something like embolic disease from AFib. You can do an echo on the chest and the heart to see if they have AFib, and then maybe showering these emboli up. You could have giant cell temporal arteritis, which causes like a vasculitis that closes down a perfusion of the ophthalmic artery. You can have central retinal vein occlusion, and you can also get papilledema that can cause it. And it's very characteristic. People actually describe it as like a transient episode of like a curtain closing down on them. And because of that, that's like how you figure out, all right, this is amaurosis fugax. Let's try to like work this up a little more. So again, we talked about the extraocular muscle lesions in the cranial nerve chapter, and I'll just briefly talk about it again. When you got a cranial nerve 3 lesion, your oculomotor nerve is going to have multiple different presentations. You're going to have inability to do itosis, and a lot of your medial rectus, inferior rectus, your superior rectus, and your inferior oblique are going to be injured in some way. You could also have pupillary dilation problems, because you can only dilate at this point, so your eye can be in permanent dilation. You could also have ciliary dysfunction you can't accommodate. So that's how you can pick up cranial nerve 3 lesions. Trochlear lesions, these are the people that can get diplopia and can't walk downstairs. That's how you're going to know this one. Cranial nerve 6, abducens, how are you going to pick this one up? This is where you're going to get diplopia, and you cannot move the eye past midline. They cannot abduct, move their eye laterally. Then you can get itosis. So we talked about it before. This is when you have some sort of injury to either the cranial nerve 3 or you have it to the sympathetic nervous system to the superior tarsal muscle. This is where pretty much ptosis just means drooping or dropping down, drooping of the upper eyelid or lower eyelid. And it can be natural. It can be just age-related, or it could also be pathologic. Things like congenital ptosis, trauma, myasthenia gravis, Bell's palsy, even Botox, botulinum toxin can actually cause it. And if it's just age-related, you can do something like a blepharoplasty to just surgically correct this problem. And then, of course, when we talk about ptosis, you gotta talk about Horner syndrome. And this is when your sympathetic's knocked out. So you can have things like transection of the sympathetic nervous system. You can actually have transection of a common carotid or internal carotid, and by association, you disrupt the sympathetic fibers passing with it. You can get a thyroid tumor that compresses the sympathetic fibers as they're ascending. You can get an aortic aneurysm, pancreas tumor. Anything that can compress the sympathetic nervous system can cause Horner syndrome. And you get the characteristic triad presentation. You get ipsilateral partial ptosis, because the main contributor to eyelid elevation is not via the sympathetic nerves. You can get ipsilateral miosis, which is constriction. And then you also get ipsilateral lack of sweating on the face. All sympathetic functions, very easy to pick up. And if something like this, someone has Horner, they tell you have Horner. Big thing that people love to test on is a Pankos tumor. And this is a tumor that resides in the apex of the lung that kind of compresses the sympathetic nerve fibers on the way up. Then you have orbital blowout fracture, which is another important clinical situation. The eyeball is a highly flexible and fluid-filled structure. It can compress. So when you have a fist to the eye or a baseball to the eye, it causes such a significant amount of intraorbital pressure that it actually will cause the medial or the inferior walls of the orbit to actually collapse. And what happens is you can actually have the contents of the eye, of the orbit, actually going into either medially or inferiorly. You can go medially into the ethmoid area. You can go inferiorly as well into the maxillary sinus. And by association, it can cause impingement of extraocular muscles. It can cause damage to nerves, vascular supply, and actually can permanently damage a lot of visual function. So whenever this does happen, it's pretty much when you have a suspected impingement that has a severe problem, you have to do some surgical treatment to kind of fix this. Then you can get superior orbital fissure fractures. So these are when fractures are close to the apex of the orbit at the superior orbital fissure, and it can cause injury to any of the associated structures that kind of pass with it. As we mentioned, the superior orbital fissure is the big gun. It's the big one versus the inferior orbital fissure. So any injury to the apex of the eye can cause pretty much obstruction or injury to the cranial nerve 2, the optic nerve, cranial nerve 3, through V1, through any extraocular muscles. You can present as someone with diplopia, double vision. You can have extraocular muscle impairment, impingement, and you can also get ptosis because cranial nerve 3 is knocked out. So last we're going to hear is finish up with the fundoscopic exam hallmarks, and this is often very much tested on, and it's actually very difficult. There's really no concise location in which you can pick up on the big hallmark pathognomonic features of a fundoscopic examination. So just for a recap, and then we'll go over the chart or the table that explains everything. Your macula is pigmented, and the macula is located lateral and temporal to the optic disc. The optic disc is medial. Your optic disc is what surrounds the optic cup. Okay, so the optic cup sits inside the optic disc. The optic disc has no rods, no cones, and is considered to be your visual blind spot. Veins are darker, arteries are lighter, and all neurovascular structures pass through the optic disc and cup, all of them. So now we're going to break down probably the most important fundoscopic examinations that you can pick up. So again, cherry red spot. This is when you have some sort of actually like almost like a hyper red spot or very much increased coloration of red in the fovea. And this can be caused by central retinal artery occlusion, Tay-Sachs, Niemann-Pick's, methanol, or carbon monoxide poisoning. You can get cotton wool spots, which are axon damage releasing axoplasmic contents. This is from diabetes, hypertension, or central retinal vein occlusion. You get swelling of the optic disc, and that's pretty much pathognomonic for increased ICP, increased intracranial pressure. So you got to think tumor, and you got to think hypertension. You can get a red reflex, which is normal. You want a red reflex. You take a light, you shine it to the back of their eye, and it should show up red. That's normal. When it shows up white as a white reflex called leukocoria, that means that there's a lack of ability of light reflecting off the vascular nature of the choroid in the back of the retina. That is a sign for retinoblastoma. You can get something called lipema retinalis, and this is when the retinal veins actually become milky white. So we said that the veins are darker than the arteries. When the veins actually are white, then you got to think this person either has high triglycerides, diabetes, or even leukemia. Then you can get neovascularization. This is when you get new blood vessels or increased amount of blood vessels that help with perfusion of the retina for some reason. There's some pathologic reason going on and why they need new blood vessels. So there's something like diabetes or macular degeneration. Then this is a very, very important one to note. You actually look at the fundoscopic examination, and it literally looks like black specks, almost like cheetah print black specks all on the macula and the retina. And this actually is an indication of retinitis pigmentosa. You can also get flame hemorrhages, which is a leakage of blood into the retina, and this can be from very chronic conditions like hypertension, diabetes, or it can be something as significant as shaken baby syndrome. You can get AV nicking, which is where the arteries cross and compress the veins at the intersection site, and actually looks like they actually stop even being continuous with one another. It's actually kind of cool to look it up, and that's usually caused by hypertension. You can get crumpled up tissue paper look of a sign as well. This is when you get exposure to the underlying retinal structures to the outside area. This is usually from a retinal detachment, which is when the retina gets detached off from the wall, it actually will crumple up like a tissue paper. And you can get a Hollenhorst plaque, and this is when you have retinal emboli, a plaque from the carotid. So when you look into the retina and you look at the fundoscopic examination, you're going to see like one white speck or two white speck right where there's a vessel, right on the vessel. And this is usually asymptomatic, but it's going to be a sign of carotid stenosis or even plaque migration, which is a significant sign for possibly consideration of like carotid endarterectomy or putting them on some sort of statin to reduce that plaque formation. And that concludes this chapter on the eye and the orbit. Again, if you have to go back for any reason at all, feel free to go back, re-listen to this, and kind of take yourself through this as much as you need to. Thank you.